Hello doctors, let's dig into some high yield pathology starting from mouth and moving down the stomach, okay? These areas are small, but the step one loves to test their diseases. Let's begin with the esophagus. When the normal squamous epithelium of the esophagus is replaced by columnar epithelium containing goblet cells, and that is Barrett esophagus. Why does this happen? Chronic acid reflux damages the lining, forcing it to adapt. Barrett is the number one predisposing factor for esophageal adenocarcinoma. And remember, adenocarcinoma is most common in the US, while the worldwide squamous cell carcinoma still leads, So again I repeat, adenocarcinoma is most common in the US, while worldwide it is squamous cell carcinoma. Step 1 also loves is infectious esophagitis. In immunocompromised patients, think of Candida, which shows white plaques. And HSV produces small punched out ulcers, while CMV gives you linear ulcers. Simple associations that can score you easy points. When the lower esophageal sphincter doesn't relax properly, we see achalasia, which we talked about in the last podcast, right? Clinically, you will spot the bird beak sign on the barium swallow, and that is very important. Then there is Zenker diverticulum. This is a false diverticulum just above the upper esophageal sphincter in the Killian triangle. And this presents with halitosis, regurgitation and dysphagia. And a classic syndrome combining the iron deficiency anemia, esophageal webs and glossitis. You remember that? And that syndrome is called Plummer-Vinson syndrome. Good. Moving into the stomach, gastroenteritis comes in two major types. One is H. pylori gastritis that starts in the antrum and can spread, while autoimmune gastritis targets the body and fundus. Very important to remember here, the autoimmune gastritis is associated with anti-parietal cell antibodies and anti-intrinsic factor antibodies, and this can lead to pernicious anemia. Now let's see about the ulcers. Gastric ulcers hurt more with food. Fine. While duodenal ulcers feel better with food. Again I repeat, this is important clinical feature. Gastric ulcers hurt more with food, while duodenal ulcers feel better with food. Duodenal ulcers are almost always linked to H. pylori. If you see an ulcer patient who feels better after eating, think of duodenum. When it comes to stomach cancer, the intestinal type is associated with the H. pylori and nitrosamines, while the diffuse type features signet ring cells and leads to linitis plastica, making the stomach rigid like leather. Remember that. Fine. One more rare but memorable condition is Menetrier disease. This causes hypertrophied gastric rugae and protein losing gastropathy. You might see this in a question stem describing enlarged rugae and low serum albumin. So here is what to remember. Barrett esophagus leads to adenocarcinoma. Squamous cell carcinoma is still globally dominant. Infections, remember 3 points here. Candida for white plaques, HSV for punched out ulcers, CMV for linear ulcers. And Zenker diverticulum, remember the clinical features like halitosis and dysphagia. About the autoimmune gastritis, and this can lead to pernicious anemia. And the pain-food relationship is very important. This can help you tell gastric and duodenal ulcers. Fine. You are building a very solid wall of knowledge in GI pathology, and these are all patterns the USMLE loves to repeat. So you are not just memorizing, you are preparing to crush those questions. Keep your momentum going, you are doing great. And I'm Dr. Ram here from MedMadness. See you next podcast.